Hello guys, welcome to our channel. Today we will be discussing of the as part of the mission 200 plus. We will be revising the pharmacology. And pharmacology is one of the most important subjects. It's like a scoring subjects. At least 10 to 15 questions can be seen in the examination. So please go through this rapid revision video and do revise the different drug of the choice and important topics. So before we start the session, those who are new to this channel, please do subscribe and share with your friends, and don't forget to watch all the 19 subjects of the rapid revision. So I am emphasizing the fact that this material is going to help you in the last minute of the examination because all the important topics and the PYTs has been covered. So please go through all 19 subjects. So if you want to have avail these books, you can join the Telegram group, and from there you can DM me for the books and PDFs of the notes. Okay, so let's start the session, guys. So first of all, I just wanted to introduce you one of the most and greatest scientist of our medical history. So he is the Alexander. So his greatest discovery, unlike the other Alexander who has conquered the different kingdoms, but this man who is actually discovered the penicillin. So this is the first antibiotic that has been discovered to kill the pathogens or the bacteria, let's say. So his contribution to today's world, still, if we are fighting with the different organisms, even though if we are get infected, so thankful to the Alexander and his contributions. So let's start with the discussion, guys. So first and foremost important is the graphs. So in the graphs, I want you guys to understand the what is the competitive inhibition and what is the uncompetitive, or sorry, non-competitive inhibition. So there are the two factors that you have to remember. In the competitive inhibition, it's a competitive is a type of reversible. Most of the times it is a reversible, and non-competitive, this is a non-competitive is irreversible. So first, please ignore these two diagrams. I will explain that later. So basically what happens? So whenever we see the drug is on the dose and how the drug is going to respond, right? So how the basically the drugs is going to respond? So generally the drug normally is going to be like this is the original drug, but we gave the drug with the antagonist. So what happens to this antagonist in the competitive inhibition? So the drug will be having the less potency. How the less potency will be seen? Always remember the potency will be on the left side. So the potency will be here, right? This is how the potency will be presented. So the drug, this is the added drug, and this is the drug that we get. So here what's the competitive inhibition? The drug will be moving to the right side. So you will be seeing the right side of the shift that will be seen in this drugs. So what happens here? Basically the Km which will be going to increase, and Vmax is constant. Vmax is constant. And next, coming to the lean Beaker curve. This is the lean Beaker curve. How can you remember? Just in the biochemistry, I have mentioned that if the two lines is meeting at the one point on the one line, then that is considered as a competitive inhibition. Next, what are the examples of these drugs? Methotrexate is one of the example, and also statins. These are the examples. And OP poisoning, this is an irreversible type. This is an irreversible type of the competitive inhibition. Next, coming to the non-competitive inhibition. So same process. This is also we are going to check for the dose, and here we are checking for the response. So we generally gave the original drug same response, that is a normal response, and after you are giving the antagonist or the drug with the antagonist, what happens? So the height of the next drug will be decreased. So the height will be decreased here, same as the height there will be decrease in the Vmax, and there is also decrease in the efficacy will be also decreased here. This is what's seen in the patients of the non-competitive inhibition drugs users. So what are the examples of the non-competitive inhibition users? There are many drugs which will be like such as poisonings. Other than the OP poisoning, we can tell different types of the scorpion bite also, even the poison with the amphetamines, different types of the benzodiazepines. All these drugs and poisons, phosphorus, arsenic, all these poisons will be coming under the non-competitive inhibition, right? Next, moving on to the another important types of the graphs that you have to remember. So let's discuss the different graphs. How can you check for the efficacy potency? So we are going to check for the drug efficacy and also drug potency. So the drug efficacy will be getting to know by us the how much the maximum effect that the drug is giving, right? This is the maximum effect. Then coming to the potency, potency is always is going to be inversely proportional to the dose, right? So that means the less potent and the less dose of the drug will be more potent, the more dose of the drug will be the less potent. So how that will be seen under the graph? So let's see, this is the one diagram we are going to check. Again, this side will be the dosage and this side will be the response of the drug. So first we are checking with the same drug and same class of the drugs also, or the different types of the drugs. Okay, so this is the drug that we gave, and other drug also we gave the patient the same condition. Let's say the patient is suffering from the bacterial infection. We gave the one antibiotic, and then we started on the patient on the different antibiotic also. We started this patient, and then also started this patient on the different antibiotic. So efficacy will be telling us about the height of the drug. Okay, this will be considered as a height. The more the height, the more the efficacy of the drug. Next, potency. Potency will be telling at the more left side. So this will lean to the more on the left side. So my same as our left side only. So this is the left, this is the right. Okay, this is the left side and this is the right. So the drug which will be the more on the left side is the more potent drug. So let's say now, based on this drug, based on this graph, this is the A, this is the B, and this is the C. Now tell me guys, which drugs are going to be the most efficacious based on the height? So the drugs will be C, A, and B, right? Based on the height, maximum effect, right? This is the efficacy. Next, coming to the potency. How the potency will be? I said more on the left side, right? And associated with the less dosage of the drug will be the more potent, right? Here the dosage curve, this is the less potent, more potent will be the, and this is the less dosage, and this is the more dosage. So obviously the less potent will be the more dosage, and the high potency will be the less dosage, right? So that means A, B, and C. This is how we are going to differentiate between the efficacy and the potency of the drugs, right? Next, we also have the therapeutic index. Therapeutic index. How can we differentiate between, how can we calculate the therapeutic index? This is recently asked in the NACT examination also. So the therapeutic index, which will be checking for the drug safety. This is for the drug safety. And how can we see that? With the help of the formula, that therapeutic index of the 50 and efficacy index of the 50. So this is the formula for the therapeutic and efficacy of the drug we are going to check, which is essential for the drug safety, right? These are the some of the important points that you have to remember. Next, coming to the another graphs also that we have asked in the examination, in the previous examinations, that you have to remember. One is the extent of the drug, one is the extent of the drug absorption, and other one will be the rate of absorption, rate of absorption. So the extent of the absorption is basically only about the bioavailability. So which drugs will be having the 100% bioavailability? 100%, that will be IV. And what about the rate of absorption? This is about the time, how much time that the drug took to act on the body. This is the extent. Next, how we can plot this under the graph. So same, we are going to check for the plasma concentration of this side, and then this is for the time. And here also same graph, this is the time and this is the plasma concentration. In the bioavailability, there are the two types. How we are going to give the oral, or either we are going to give the IV most of the times. So these patients, this is the area under curve. Okay, this is the area under curve, which is oral. Next, this is the another area under cover, right? This will be area under curve, which is IV related. So this is how we are going to check for the bioavailability of the most of the times for the extent of the absorption. And next, coming to the rate of the absorption. So this will touch the line, and that will check for the, this is the maximum plasma concentration, and this is the maximum time that we reached for the drug absorption. This is how we are going to check for the extent and the rate of the absorption. Next, another important points that you have to take note about the drug kinetics, how the drugs are going to be eliminated from our body. This table has been also asked in the very recent examination that has been conducted, right? Next, we will be checking for the drug kinetics. One is zero order and other one is the first order. So zero order, this is the graph, and the drug elimination will be at the constant per hour, constant amount per hour. Let's say this is how the graph, for example 5 mg and another 1 hour 5 mg, another 1 hour also 5 mg will be decreased. This is the zero order. Whereas first order, the drug here is going to be decreased in the proportionate. For example, 5%, then the 5%, then the 5%. So what is the difference between the zero order and the first order? So zero order, which will be associated with the more toxicity, and here this will be less toxicity. That is the main difference between the zero order and the first order, because here the T half life will be increased. Here the T half life is constant. There is nothing is going to be changed, right? For example, if I gave the 100 mg of the drug, after 1 hour it is just 95 mg is decreased, right? If I gave the 100 mg of the drug here, in that 5% of the drug will be decreased, almost the proportion will be decreased here, right? It could be 90 or 80, and after 1 hour again 5% will be decreased, it will be 70 or the 60. This is percentage, so the drug is eliminating from the body. So this is more safer comparing to the zero order. So that's why it is associated with the toxicity, it is associated with the less toxicity. Examples are most important for this. So zero order kinetics are most commonly your phenytoin, and also anticoagulant drugs such as heparin and the warfarin. These two drugs can be, and also theophylline, and remaining all drugs can be come under the first order kinetics. At least remember these examples. They are the other examples of the zero order also, but remember these are the some of the examples for the first order kinetics, right? These are the important points that you have to remember. Next, drug absorption, how the drug is absorbed. So most of the drug will be absorption by the small intestine. This will be from the small intestine, and these drugs which is absorbed by the small intestine are in the form of ionized form, and they are highly lipid soluble drugs. Next, coming to the elimination, how the elimination will be opposite to the absorption. Elimination of the drug will be from the kidneys, and this is ionized drug. These are the ionized drugs and highly water soluble. And how these drugs are eliminated? Is it by the tubular filtration or the secretion? So whichever we are throwing from the body, that is the secretion. So these are also gone from our body with the help of the tubular secretion, right? These are the important points that you have to remember, and some of the mechanisms and those drugs will be discussed here only. Next, drug receptors, that is also very important. What are the different types of the receptors that will be seen? If it is related ion related or the ion receptors, these are GABA A drug, or the glutamate drugs, and also nicotinic. These are the ion related drugs. Next, enzyme related such as Tyrosine kinase, first one that you have to remember is the insulin and also IGF, insulin like growth factor and toll like receptors, right? Next, another one will be the drugs that will be associated with the GPCR, right? GPCR, G protein coupled receptors. In that, remember the GS examples. These are the drugs with the beta 1 and beta 2. Next, GQ. This will be with the help of the alpha 1, M1 and M2. Next, GI. So whichever is left in the GQ like alpha 2, M2, sorry, this is the M3 guys. M alpha 1, M1 and the M3. Okay, next here the alpha 2 and the M2 and also 5HT1. This will be also seen in the GI. So what are the other things that you have to remember at these points in the receptors is this is the action with the help of the CAMP. Okay, this is the help with the action of the increased CAMP and this is the help of the action with the IP3. And here it is opposite, it will be decreasing the calcium, also it will be decreasing the CAMP, right? These are the GPCR receptors and other important points that you have to remember about these kind of drugs receptors, right? Next, coming to the important points which will be related to the drug inducers and the drug inhibitors. So let's discuss those drugs later. First, after the end of the topics, I will be discussing the more miscellaneous topics of the general pharmacology. Okay, now we will be coming back to the classifications, different drugs and different classifications we will be discussing. First one is the diuretics. This is the most important carbonic anhydrous drugs and it can be asked by the image based question also. In the proximal convoluted tubule, here exactly the drugs that is associated as the acetozolamide. What are those drugs? Carbonic anhydrous. Next, here in the drugs, this will be the mannitols. These are the osmotic drugs. Next, ascending loop of Henle associated with the loop diuretics. And next, in the distal convoluted tubule, these are the thiazide drugs, and in the collecting tubules, this is the potassium sparing drugs. Right, one by one, the what are the tubules and what are the drugs will be associated. As I said, this is associated with the carbonic anhydrases. Right, these drugs are carbonic anhydrase, which will be inhibitors, not the activators. These are the inhibitors. What will be the drugs, common drugs? That is the acetozolamide. Acetozolamide. This is a oral drug, right? Next, what is the mechanism of action? As we discussed, this is the carbonic anhydrase inhibitors. So HCO3 or the H2O2 or different, all of this will be decreased and different the elements that will be giving for the hydrogen secretion that will be decreased. So that means the drug is actually doing the body, it is characterizing the drug to cause the more and more acidosis, right? The secretion of the this going secretion of the hydrogen ions are decreasing, so our body will be becoming the more acidotic. So these kind of the drugs, acetozolamide, which is causing the acidosis in the body, which conditions we can use this drug? For example, high ventilation, high high ventilation or the hyperventilation or the high altitude sickness, right? In these situations, alkalosis is producing. What we have to do, we have to decrease the hydrogen going out, so we can give this drug for these patients. And also acute closure glaucoma, because the carbonic anhydrase is present in the eye also, you have to close that one also. And also those who are suffering from the metabolic alkalosis patient also, we can give this drug. And what are the side effects associated with this drug? The first and foremost common is the metabolic acidosis, and it can also cause the nephron stones. Okay, nephrolithiasis stones will be also seen in this patient. And associated, if it is given, it can cause the sulfa allergy, those who are allergic to the sulfa. And also liver failure patients, it should not be given because it can build up the ammonia. So that's why liver failure patients, the drug should not be given. Next, this is the loop of Henle. Loop of Henle, the drugs are the osmotics, right? The one of the examples of the osmotics will be the mannitol drug. And these drugs which will be increasing the tubular osmolarity, this will be only and only involving the H2O, and it will involve the osmolarity of the tubules. What are the conditions that we can give for this? This is given in the cerebral edema patients, and also those who are having the increased intracranial tensions, those patients also we can give for this drug, and also those who are suffering from the diabetes disequilibrium condition, dialysis disequilibrium condition also we can give this drug. And what happens, this drug means it is highly acts on the cells in the different way, in the cellular level and the nephron level it will be acting different way. That's why we don't give the patients of the congestive heart failure, and also those who are having the severe hemorrhage, we are not going to give for this patient. Only most of the conditions will be the trauma patients or patients who are suffering from the ischemic strokes we can give, those who are suffering from the increased intracranial tension. Remaining patients we are not going to give. This has been contraindicated. Next, descending loop of Henle. So in the descending loop of Henle, this is going to act on the thick loop of Henle. Thick loop of Henle. Right here you can see this is the thick loop of Henle. So please take note, this is the ascending loop. Thick ascending loop of Henle. This drug is going to act. What are those drugs? Loop diuretics. And drug name, one of the example is the furosemide. This is a drug. And what are the mechanism of action? In the thick ascending loop of Henle, there is a potassium, sodium, and chloride. All these elements are going to be absorbed. So we are actually blocking them. So this absorption is decreased rather than it is going to be secreted from the tubules. So these can be used for the hypertension patients, and also congestive heart failure patients we can use, and also those who are suffering from the most commonly pulmonary edema. Okay, pulmonary edema patients also we can use this drug. This is the one of the most important drug we can use. Next, side effects. So side effects is most commonly this drug loop lose everything. Remember the mnemonic, loop lose everything. Sodium will be lost, potassium will be lost, chloride will be lost, calcium will be lost, magnesium will be lost, everything, loop lose everything. Next, coming to the other side effects, it can cause the gout, it can cause the diabetes mellitus, hyperglycemia will be seen, highly ototoxic drugs, and this can also increase the lipids. These downward will be increasing, and the upper line that the elements will be decreasing from the body. This is the one of the disastrous causes of the drugs that will be seen with the condition. Okay, next, DCT. In the DCT, the drugs that are acting is the thiazides. Okay, one of the examples of the thiazides will be chlorthalidone. Remaining all the drugs will be associated with the thiazide in the name itself. Okay, that's how you can remember. And again, in this DCT also, there is a sodium channel and also chloride channel. We are going to block this. So this will be decreased, inhibition will be seen here. And this is also again given for the patients of the hypertension, and also those who are having the nephrogenic. Okay, remember this is a nephrogenic type of DI. Okay, diabetes insipidus, not the diabetes mellitus. This is the diabetes insipidus. And also those who are suffering from the calciuric stones. Calciuric stones also we can give for this patient. And also those who are suffering from the osteoporosis with hypertension also we can give this drug. Those who are suffering from the CKD with normal calcium patients also we can give this drug. Next, what about the side effects of these drugs? There are many side effects of the drugs. Similar to that, it will decrease the sodium, it will decrease the potassium, and also it will decrease the chloride, it will decrease the magnesium, except there is a normal calcium. So calcium is not excreted from the thiazide drugs. Calcium will be staying the normal. That's why we are giving for the hypercalciuric stones. So the calcium levels will be maintained in this drug. So that will be treated with these drugs. And next, it can cause again gout will be seen with this patient also. Lipids will be increased in this patients also. Diabetes mellitus patients also seen with this condition. And other one is the metabolic alkalosis will be seen. Here also you can add this is associated with the metabolic alkalosis. Okay, remaining all the same side effects that will be seen. Okay, next moving on to the another type, last type. This is the collecting tubules. Collecting tubules, we have the drugs that is a potassium sparing drugs, right? There are the two types. One is the ENaC channel blockers. This is the epithelial sodium channel blockers. What are those three drugs? One of the examples is the spironolactone. This drug is present. One, and next one, there is a drugs that can be associated with the other androgen also. Okay, these are the other androgen blockers. What are those drugs? Amyloid drugs, right? These are the two present in the potassium sparing agents. Next, what is the main mechanism here? Basically, aldosterone is going to act here. What does the aldosterone will do? It will do the iron reabsorption, and it will excrete the potassium. It will excrete the potassium, right? This is the normal function. So what we are doing in this patient is same mechanism. We are actually activating the aldosterone. When we are activating the aldosterone, that will be the normal function, but these are potassium sparing agents, so that means potassium has to be not excreted. So these drugs is not actually normally not is the normal function of the aldosterone. It will block the aldosterone. That's why I say this is a ENaC channel blockers. Most of the peoples will be confused between this aldosterone mechanism, but we are actually blocking the aldosterone drop. So what happens overall effect if we block with the aldosterone? So the potassium from the body, so the sodium from the body will be decreased and potassium from the body will be increased, right? This is the effect of the drug. This is the drug effect. That is the drug effect that we are going to see. Next, what are the conditions that we are going to use? We are going to use those who are suffering from the Cons syndrome, those who are suffering from the Liddell's syndrome, and those who are suffering from the ascites. Okay, ascites patient also we can give this drug, and whoever is not controlled with the resistant hypertension also we can give this drug. Congestive heart failure patients also we can give, and the amyloid can be given for the cystic fibrosis patient, and also it can be given for the one of the condition nephrogenic DI. So, but you might have already got the doubt here. Already we are giving the nephrogenic DI. Then again, why the nephrogenic DI here? So this is associated with the lithium induced nephrogenic DI, because lithium thiazides can be even more toxic. So that's why for this specific condition associated with the lithium, we can give the spironolactone. What is the patients those who are suffering from the side effects? What is the side effects that we can expect in this patient? So potassium sparing agents, obviously it will increase the potassium, and that can cause the arrhythmias in this patient, right? Arrhythmias will be seen. Along with that, it is androgen blockers, so impotence can be seen, infertility will be seen, right?
These are
And in
the
the
important
highest doses,
points
it can
and the
also cause
diseases
the
that you have to remember
gynecomastia
in this
in the male
condition. Those
patients.
who are new to
Right?
this
These are the
channel,
side
please do
effects of the
subscribe.
collecting tubules that you have to remember for the diuretics and their important function. Right? Next, moving on to the statins. So statins classification is also very much important. So not just statin, I'm going to discuss here about the anti-lipid drugs, all the anti-lipid classifications. Statins. First, let's start with the statins. And in the statins, the most common drugs that we use is the atorvastatin, rosuvastatin. These are the drugs that we use. What is the mechanism? The Hmg CoA reductase. Hmg CoA reductase is blocked in this patient. So these affect the cholesterol pathway. When it is blocked, it is going to decrease the LDL. Maximum of the LDL will be decreased in this patient. Along with that, VLDL will be also decreased, and some mechanism it can be also increase the HDL. But it has a special effect. The statins have the one of the most important effect, that it is a pleural effect. Okay, multiple pleural effects will be seen. Okay, pleomorphic effect that we call. It can be antioxidant. It can be antioxidant. It is anti-lipid drug, and it can be also anti-angiogenic drug and anti-aggregant drug. especially with the platelets. All these multiple effects, so that's why we use the commonly the statins as a first line of therapy for the patients. But highly hepatotoxic, these drugs are the highly hepatotoxic drug, and it can cause the severe myopathy. Okay, the one of the myopathy's causes will be statin drugs only, and over the time it can also increase the insulin resistance. If you're giving the heart patients, if they are not diabetic patients, they can develop the future diabetes mellitus will be also seen. Okay, next moving on to the another classifications. So these are the fibrates. Okay, these drugs are the fibrates. One of the examples is a fenofibrate. Fenofibrate is all the drugs will be associated with the drugs phenophy, the name fibrate only. So this is acting on the nuclear PP, PPAR gamma. So this will be acting on the PPAR gamma receptor or the enzyme. So what it will do, it will increase the LPL. It will be increasing the LPL activity. So what happens, this LPL activity will, it will increase the triglyceride clearance from the body. Okay, it will be increasing the triglyceride clearance of the body. So further it will decrease the triglyceride from the body and also decrease the VLDL from the body. Next, but it is associated with the severe gallstones. It will be associated with the gallstones and also myopathy. So two most drugs that will be causing the myopathy, one is the statins, other one is the fibrates. That is the drugs that can be causing. Next, another one is the bile acid binders. Bile acid binders or the analogs we can say. The examples are, these are the associated with the name cola itself. Okay, cholecalciferol, one of the example. So these bile acid binders, what they do, so same, it will be binding with the bile acids. It will be binding with the bile acids, and bile acids which will be associated with the fats emulsification, right? Fat emulsifying. So it will be having the more and more enterohepatic circulation, so more metabolism process will be seen, so conversion is decreased. So more the circulation, so the more the conversion will be decreased, and overall effect will be decreasing the LDL from the body. But it can be deceived, it is increasing the enterohepatic circulation, so obviously the patient will be having the GI upset. GI upset will be seen, and it is decreasing only the LDL. Indirectly it will increase the triglycerides in the body. And also these patients benefit of this drug, this is safe in the patients of the pregnancy, because it is only acting on the enterohepatic circulation. And infants, those who are born with the cholesterolemia conditions, their patients also we can give. That is a benefit of the bile acid binders. And GI upset, as I said, this can be also causing the pancreatitis also. Rare side effects that will be also seen here, right? Next, the last one, that is a niacin. Niacin is a B3 drug, right? And niacin is actually going to decrease the VLDL. This is going to decrease the VLDL, and this will be decreasing the LDL, and maximum it will increase the HDL. Okay, maximum it will be increasing the HDL of the body. But can we also take, because it is a vitamin? No, because this is the vitamin B3, it can cause the flushing. Okay, because it is going to act on the tryptophan. More and the more tryptophan, more and the more niacin, it can cause the flushing. And it can also increase the glucose levels. Irregular glucose levels will be seen, and gout is also increased here. Okay, and what is the main mechanism? Is actually it is acting on the HPL, hormone lipase protein, that is going to increase. Okay, that is due to niacin. Next, one of the drug that you have to remember, at least in the name, that is a PCSK9 inhibitors. PCSK9 inhibitors, these drugs are evolocumab. Okay, these drugs are evolocumab. Okay, and it will be decreasing the LDL by the receptor blocking, by the receptor blockers of the LDL. These are the evolocumab. Next, moving on to the anti-arrhythmics. Anti-arrhythmics are the different classes that you can see here. The class 1, which will be blocking the sodium. Class 2 is going to block the beta blockers. Class 3 is the potassium. Class C is the calcium channel blocker. So you can remember with the mnemonic of the class 1, 2, 3, 4. So this is a sodium channel, this is a beta blocker, and this is the potassium channel blocker. So this is the potassium channel blocker, and this is the calcium channel blocker. Sonali Bindre, Priyanka Chopra. Just remember the mnemonics: Sonali Bindre, Priyanka Chopra. These are the blockers of the different classes of the drugs. We have the miscellaneous class also. That is a class 5. Next, class 1 drugs. Let's see one by one. Class 1 drugs. So as I said, this is going to block the sodium channel, right? So class 1 drugs most commonly act on the sodium channel blockers, but subclassified as 1A, 1B, and 1C. Let's see mechanism. So class 1A is going to block the sodium channel. Okay, next, as well as it will be also blocking the potassium channel. Next, class 2. This is going to block the sodium channel, but potassium channel is open. Next, IC. This is going to block the sodium channel, but no role of the potassium. No role of the potassium, right? This is the main mechanism of the different drugs. Next, what are the names of the drugs that you have to remember? Quinidine, one of the drugs, and prokinamide is one of the drugs, and the B drugs are the lidocaine and also maxilitine. Next, 1C drugs are the flecainide and also propafenone, propafenone. Okay, these are the drugs. So I hope you guys, the sound must be disturbing you guys, sorry for that. But here the most of the side effects that you have to remember. So 1A class of the drugs, it can increase the QT prolongation because we are blocking the potassium also. If you block the potassium, it can cause the QT prolongation, and it can cause the SLE, which is associated with the drug induced type of the SLE also. And quinidine is drug can cause the synchronism. It can cause the synchronism in the patients. Next, coming to the 1B drugs, this can cross the blood-brain barrier. It can trigger the tremors also, and sometimes seizures will be also seen in this patient. Next, 1C drugs, they themselves or the most of the arrhythmias can be caused by this drug. So that's why it is also known as a pro-arrhythmic drugs. So in the patients suffering from the MI, acute MI, we can avoid the flecainide as a drug of the choice. Next, prokinamide, it can be given for the patients of the WPV syndrome. These patients we can give the prokinamide drug. Next, class 2 is the beta blockers. Class 2 drugs are the beta blockers. What are the examples, guys? You can remember metoprolol and also esmolol, atenolol, right? Landiolol. All these lol drugs will becomes under the class 2 drugs. And mechanism of that is basically it will be decreasing the PR interval. Okay, it will be increasing the PR interval. So further it will be decreasing the SC and AV conduction. So this is the main mechanism of the arrhythmia purposes of the drug. So most common side effects will be decreased heart rate, right? It will be going to decrease the heart rate. AV conduction is decreasing. So obviously the AV blocks will be seen in this patient, and beta blockers can cause the bronchospasm, right? Bronchospasm can be seen, and it can also mask the hypoglycemia symptoms will be seen. So these are the basic contraindications. Asthma patients we are not going to give, diabetes mellitus patient not going to give, MI patients is not going to give. So these are the common side effects associated with the beta blockers. Next, class 3 drugs. Class 3 is what is the mechanism, guys? Class 3 will be the potassium channel blocker, right? Class 3 is the potassium channel blocker. Common drug, that is the sotalol. So you might be think all the lols will be the beta. So these sotalol have the special effect. It can be blocking the potassium channel also. It can be beta receptor also. So that is the best of the sotalol. And one of the other example is the ibutolide. Okay, ibutolide and also amiodarone drug. So third class of the drugs, as I said, potassium channel. So what it will do, it will increase the QT prolongation. So as a normal effect only, it will be increasing the QT prolongation. So further action potential, okay, action potential of the total ventricle will be increased with this drug. So the side effects will be the maximum QT prolongation associated with the drug, that is ibutolide. Okay, the drug that is the ebutalide will be having the maximum QT prolongation and minimum QT prolongation. This is associated with the amiodarone. So just in a while, I will be discussing about the amiodarone also, what is the importance of the amiodarone. So this is the QT prolongation. So if this QT prolongation is increased, this can cause the torsades de pointus, right? Torsades de pointus, and severe death is also seen in this patient. Next, class 4. Class 4 drugs are the calcium channel blockers. This is the non-DHPR receptors. Okay, non-dihydropyrimidine receptors. This is associated with the calcium. Examples are the verapamil and also deletiazem. Okay, deletiazem. So these drugs, the main mechanism will be again increase the PR interval, and decrease the node conduction. AV node conduction, and these drugs which will be associated with the constipation. Okay, it will be decreasing the constipation because the calcium channels can block in the colon also, and decreased heart rate. Obviously, there will be blocks can be also seen, and other gingival hyperplasia. Okay, gingival hyperplasia is also seen with this condition. Why the verapamil is best? Because these verapamil can be given if the patient, those who are asthma. So asthma patients I can give if they are presented with the PSVT or AFib or any heart rate condition. If they are associated with the asthma, I can safely give the verapamil for this patient. Next, class 5, we have the different drugs like atropine, MGS44, adenosine. The drugs are there. So class 5 drugs, atropine, the drug of the choice for the bradycardia, right? Next, adenosine is the drug of the choice for the patients those who are suffering from the PSVT. Next, MGS04 is the drug of the choice, especially the torsades de pointus. Digoxin is drug of the choice in some congestive heart failure patients, right? These are associated with the class 5 miscellaneous. Okay, multiple different actions that will be seen in the miscellaneous drugs. Next, we will be discussing of the oral hypoglycemic agents, one of the most important topic of overall all the pharmacology. This is the most important topic for your future also. Okay, that should not be ignored. So one is the biguanides. Okay, one is the biguanides. What are the examples of the biguanides, guys? That is the metformin drug. And the main mechanism of these one is that it will decrease the hepatic glucose. It will be decreasing the hepatic glucose production. Also, it will be decrease the overall the time insulin resistance will be also decreased, and the pathway that will be following is the AMPK pathway that is followed by this drug, and over the time it can also decrease the LDL. So that's why my best choice for this is it is a drug of the choice for the patients those who are suffering from the type 2 diabetes mellitus. Okay, type 2 diabetes mellitus, but it is associated with the severe side effects also. So the side effects will be if the patient is 30% of the GFR, end stage renal disease. So this drug is contraindicated. I have to shift for the other drug. It can cause the lactic acidosis also. Okay, in the early cases, in the mostly in the females, it can cause the lactic acidosis, and B12 deficiency will be also seen with this biguanides. Next, the best drugs, those are the common combination with the biguanides we use. Those are the sulfonylureas, these drugs, and the drugs that is the glimepiride. Okay, that is the glimepiride. So these glimepiride drugs that can block the pancreas beta pancreas of potassium channels. Okay, potassium channels. So further, it will be increasing the insulin secretion in the body. So this is the mechanism, but this is highly associated with the hypoglycemia, very high. Even the small dosage can also cause the hypoglycemia. Weight gain, which will be seen, so contraindicated in the heart patients. contraindicated in the heart patients. Another type is the meglitinides. These are the meglitinides, but these meglitinides is a similar action only, but short duration, which will be seen same action only, same action, but this is the short acting drugs. Next, DPP4 DPP4 inhibitors. DPP4 inhibitors. These drugs will be ending with the gliptons like sitagliptin, right? Sitagliptin, linagliptin, all these drugs will be seen. All these DPP4 inhibitors, what they do? The main mechanism of them is the increase the incretin. Okay, increase the incretin. What does this incretin will do? It will do the two effects. One is it going to decrease the glucagon, it will be increasing the insulin. So if the glucagon is decreased, it will also decrease the satiety. Okay, and gastric emptying will be decreased. Gastric emptying will be decreased in our body. So this is the indirect effect of the DPP4 inhibitors, but it is not renal safe, renal unsafe drugs. But one drug that can be given for the patients of the renal safe also, that is the linagliptin. Linagliptin is works as a renal safe drug. It going to be renal safe. It is acting on the GI. Incretins is present in the GI system, so it can cause the pancreatitis. So rare side effect, but it can cause the pancreatitis, and it is associated with the weight loss. Good weight loss drugs are the these DPP4 inhibitors. Next, agonist, GLP agonist. So these all are going to be the subcutaneous drugs only available. Liraglutide, liraglutide, and the famous drug that is the semaglutide. Okay, semaglutide. These are the drugs. Same action again. It will be acting on the incretins only. Okay, so it will decrease the glucagon, increase the insulin. Right, decrease the glucagon and increase the insulin. What is the side effects that will be seen? These are renal safe. These drugs are the renal safe, can be given, and also associated again pancreatitis, which will be seen, and weight loss. Good weight loss drugs are commonly with this GLP agonist only. Next, another one that is recently has been approved. This is the gastrointestinal inhibitor peptide and also GLP inhibitor. Both are okay. What is this drug? This is newly came into the market, that is the terizipatide. Okay, both action will be seen here. GIP and also GLP-1, that is both seen in the terizipatide. Next, SGLT2. SGLT2 inhibitors. These are the drugs are the inhibitors. So what does this SGLT2 inhibitors will be doing, guys? Mostly, let's see the mechanism. So these drugs ends with the gliflozins. Canagliflozin ends with the gliflozin drug. This is act on the kidneys, and in the kidneys it will be acting on the PCT. So PCT we having the SGLT2. So if I block this SGLT2 inhibitor, so what happens? So the glucose is not going to be reabsorbed into the body. So the glucose will be going into the urine. So that is the presentation glucosuria with these drugs. So if you are having the glucosuria, these are the best drugs, right? So you are actually sending the more fluid, because the glucose is having the osmotic property, more water will be going from our body. So this drug is drug of the choice who are suffering from the congestive heart failure with the diabetes mellitus. We can give this drug. Okay, next, the side effects is commonly UTIs, vaginal infections, okay, females, and also dehydration, and euglycemic euglycemic diabetes ketoacidosis, and weight loss. These are the side effects of the SGLT2 inhibitors. And also the last few classifications, guys, that is the amylin analogs, amylin agonist. So the drug is the pramlitide. So here itself the amylin is given in the example. So this is a subcutaneous type. I can give for the type 1 diabetes mellitus I can also give for the type 2 diabetes mellitus. Amylin is released from the same body, right? Insulin, C-peptide, amylin is together released. So again, it will be increasing the insulin secretion in the body, and it will decrease the glucagon, and further it will be also decreasing the gastric emptying is also decreased from this. So it can cause the, due to its associated with the injection, it can cause the hypoglycemia, but rarely hypoglycemia is also seen with these patients. Next, alpha glucosidase drugs. These are the blockades where this alpha glucoside is present. So these examples are vaglibose, acarabose. Okay, next, where this is present in the GI system. So in the GI system you are blocking this alpha glucosidases. So obviously the patients, those who are blocked with this, so carbohydrates are going to be, absorption is decreased, so they are just came in and they are going to excrete from the body, so the absorption is decreased, so obviously the patients will be having the less appetite, so more calorie restriction will be seen with these patients. It is acting on the GI. So GI patients will be having the diarrhea, flatulence and also diarrhea will be seen. And those who are suffering from the cirrhosis patients, so cirrhosis patients, this is the contraindications. Okay, this is a contraindication for the cirrhosis patient. Okay, these are the some of the examples that you can remember. And the last classifications is the thiazolidinidoins. Thiazolidinidoins. This is the names of the examples is the glitazones. Okay, pioglitazone, pioglitazone. Okay, this is the drug, and this will be acting on the, again, PPAR gamma receptors. This will be acting on the PPAR gamma receptors on the periphery. So it will be increasing the insulin. So it will be increasing the insulin secretion in the body. And this is renal safe. These are the renal safe drugs, but it is associated with the bladder cancer. Bladder cancer will be seen. Congestive heart failure patient, it is contraindication, and it can also cause the fractures. Okay, it can also cause the fractures and weight gain. All these are the side effects of the last classification of the drugs. Next, moving on to the importance of the acute and the chronic type of the heart failures. So let's say you have the presentation of the acute patient. So in the acute patients, what you can give? So first and foremost thing that you have to give in the acute patients is the diuretics. Diuretics can be given for this patient. And next, you can also give the ionotropes. Ionotropes should be given for this patient. And on add-on, you can use the ACE and ERB inhibitors can be given for this patient. Okay, in the acute presentation, mostly beta blockers is sometimes given, sometimes not given. In the chronic patients, you are actually giving the decreasing the mortality. So first you are going to add the ACE or the ERB inhibitors you are going to add. Along with that, you are also going to add the diuretics for this patient and sacubitril. So what is the mechanism of this sacubitril, guys? So this is going to act on the nephrolysin, that is the sacubitril is going to add. Along with that, you can also add the digoxin, and plus or minus beta blockers can be also added for this patient. This is the therapy. But I want you guys to understand that some of the drugs will be decreasing the mortality of the patient. Some of the drugs will be decreasing the mortality. What are those drugs? So first and foremost, that is the ACE and ERB drugs, and also the drugs such as ARNI, which is just now discussed, that is the sacubitril. And next, beta blockers can be decreasing, and diuretics such as spironolactone drugs, and also SGLT2 inhibitors we can add, and we can also add the nitrates. These drugs will be decreasing the heart failure mortality rate. So that's why which are commonly used for the heart failure patients, and it will improve the prognosis of the patient. Next, moving on to the anti-glaucoma drugs. So we have the different classifications. One is the prostaglandin analogs, right? Another one is the beta blockers. Next, alpha 2 agonist, so increasing the alpha action. Next, carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. What are the examples are this? This is the latanoprost. This is a timolol, the drug that is available, and here we have the apraclonidine, and also we have the brominidine. And carbonic anhydrase, only drug that is available, that is the acetazolamide. That is the acetazolamide. We can also give the natrosodil, another combination. This is the rho kinase inhibitor. This is the rho kinase inhibitor, that is the natrosodil drug. Let's see one by one what is the mechanism and what is the side effects. So mechanism of action for the prostaglandin, it will be increasing the uveoscleral pathway. So it will be increasing the uveoscleral pathway. We have the two pathways, one is the trabecular, other one is the uveoscleral. So if the patient is suffering from this glaucoma, we can divert that to the uveoscleral pathway. And beta blockers will be decreasing the production. So aqueous production is decreased here in the beta blockers patients. So same as the alpha also, they are going to decrease the aqueous production. Also, they are going to increase the trabecular flow. Trabecular flow is also increased here, and it will be decreasing the aqueous flow. Aqueous production, sorry. Aqueous production is decreased. Same as here, it will be decreasing the aqueous production. Right, this is the main mechanism of all the drugs. Next, what is the side effects? Side effects is very commonly asked. So first, it will be causing the eyelash growth, extra eyelash growth, which will be seen, and it can cause the uveitis, and also cystic macular edema will be seen in this patient, and iris color change, or we can say increase the pigmentation. Iris pigmentation is also seen with the prostaglandins. Next, this will be associated with the BBC, beta blockers. What is the BBC? One, it will be causing the bradycardia, obviously, and next, in the eyes, it can cause the blepharoconjunctivitis, which will be seen with this. And another B is going to be the blockage. What is the blockage, guys? Nasolacrimal duct, that is going to be blocked. And for the C is for the corneal anesthesia. Corneal anesthesia will be also C. Next, coming to the alpha. Alpha is going to be cause the eyelid retraction. Eyelid retraction will be seen, and also follicular conjunctivitis. It can cause the follicular conjunctivitis will be also seen in this patient. If it is cross the blood-brain barrier, it can cause the depression, and babies, if they are children, it can cause the drowsiness, and also it can cause the apnea. So that's why this is contraindicated in the children. Okay, all these are severe symptoms if they are crossed a blood-brain barrier. And this B drugs is associated like blood-brain barrier crossing, that is associated with the brimonidine. Right? Next, acetazolamide, it can cause the GI upset, and also it can cause the renal stones, and in the high doses it can cause the metabolic acidosis. Right? Next, this aqueous, this is the natrosodil. The natrosodil can be associated with the corneal verticilla side effect. That's it. These are the important drugs of the anti-glaucoma drugs that you have to remember. Next, the most important, that is the tubercular drugs. Tubercular drugs, that is a very very important, guys. The first one is the rifampicin. Okay, rifampicin, and other one is the isoniazid. This is the pyrazinamide and ethambutol. So what are the mechanism of these drugs? Rifampicin, isoniazid, and the different drugs. So the drug that is associated with this one, it is going to block the RNA polymerase blocker, which is DNA dependent. So DNA dependent RNA polymerase is going to be blocked, right? That is the first mechanism of the rifampicin. Next, second one, isoniazid, it is going to block the mycolic acid. Where this mycolic acid is present, guys? In the membrane, right? In the cell wall. So it is going to block the cell wall, break the cell wall by blocking the mycolic acids. Next, what about the pyrazinamide? Pyrazinamide, the main mechanism will be cell membrane disruption. How it is going to disrupt the cell membrane? It is going to block the cell membrane by blocking the free fatty acids, because the more lipopolysaccharides can cause the strongest the cell wall membrane, right? So it will be going to decrease the cell membrane of the pyrazinamide. Next, cell wall synthesis. If I block the cell wall synthesis, that will be the ethambutol. That is the ethambutol. Next, the notable side effects that you have to take note. All are going to be the hepatotoxic. All are going to be the mostly hepatotoxic. All are contraindications for those whoever is suffering from the hepatotoxicity. Next, what are the other side effects? So, rifampicin can be causing the orange fluids in the body. So it will be causing the orange fluids in the body, and it is also known as a CYP450 inducer. CYP450 inducer. Next, coming to the isoniazid, it can be causing the periphery neuropathy. So these patients will be having the neuropathy. Why the neuropathy is seen in this patient? Because it is decreasing the B6. You have to supplement the B6 for this patient. It can cause the SLE, drug induced SLE also seen, right? Next, coming to the hepatotoxicity, it can cause the gout. It will be inducing the gout in the patients. And the ethambutol, E for ethambutol, E for eye. So it will be causing the neuritis. Just remember optic neuritis, that is also seen. And even in the extent, it can cause the renal failure. It will be causing the renal failure. So new regimen is following this way. Old regimen, how we are going to see, guys? In the old regimen, we are going to see the different types, right? For example, first we are going to give the 6 months. In the 6 months, 2 months is the intensive, and another 4 months is the continuous, right? This is how we are going to follow. So this is all the drugs HRZE. So now it is only HRE, right? I'm sorry, this is the old. So new is going to be intensive phase is 2 months, and also sorry, intensive period also 2 months, and the continuous period also 2 months, and it is replaced by the HRMZ, and it is only HRM. Okay, these are the drugs that we are going to give. So ethambutol is replaced by the moxifloxacin. What is this M? This is the moxifloxacin. This is the drug that is replaced with these drugs. Okay, and the revision also, this has been given into the 4 months only. Right now this is not yet implemented in India, but this is the worldwide, that is a new addition that has been came for these drugs. Okay, next, moving on to the other classification that I want you guys to remember is the malarial drugs. What is the malarial therapy that we are going to follow? Okay, malarial drugs, we have the different types, right? Vivax patients. So in the Vivax patients, we are going to give first, that is a chloroquine, and along with that primaquine. This is the commonly that we are going to follow the patients of the Vivax, right? This is how we are going to follow. Next, coming to the falciparum. This is quite different with the falciparum patients. This is different? Let's see. In all states, in the all states of India, and then northeastern states. So patients in the all states, we are going to follow the therapy of the artesunate and also sulfadoxine and pyrimethamine. This is followed in the all states. In the northeastern states, I use the artesunate and lumafentrin and artemether. These drugs I will be using in the northeastern states, and these are the drugs that I am going to use in the all state patients. So, and add-on drugs on the day 2. Here also add-on drugs on the day 2. So day 2 I am going to give the primaquine. Here also I'm going to give the day 2 prima cui. This is most important therapy that you have to know about the falciparum, right? These questions can be asked in the examination also. Next, coming to the migraine. So migraine, the drug that we are going to use in the acute stages. So those who are presented with the acute stages, I can give the NSAIDs. If I say this is a drug of the choice for this patient, then I'm going to give the triptans. Triptans can be given for this patient, right? This is the main drugs that I'm going to use. What about the pregnancy patient? Pregnancy patient also I can give the triptans only, but mainly it is going to be coming with the importance of the drugs is going to be prophylaxis. So here plays the major role, that is a prophylaxis. Prophylaxis drug of the choice here is the propranolol. Okay, propranolol is a drug that we are going to give for this patient. Next, other than that, what we can give? We can give the topiramate. Topiramate can be given for this patient, and also flunarizine. Flunarizine can be given for this patient. Amitriptyline can be given. Okay, amitriptyline can be given, and also they are some of the blockers. Those are known as a CGRP drugs. These CGRP antibodies, these drugs are known as a gala galcanezumab and irunumab. These are the two drugs that we can use for the CGRP blockers, and also botulinum toxin. Botulinum toxin can be also given. This can be also given for this patient, right? This is the migraine therapy that you have to remember. Next, coming to the ANS drugs is very commonly asked in the examination, and also that you have to remember what is the importance of the ANS drugs. First, you have to take note about the what is the main mechanism of this, right? First, what is the main function of the parasympathetic nervous system? Where they are presented? They are present in the 3, 7, and 9 and 10 cranial nerves, and also S2 to S4 sacral ganglia is also present. And what is the main mechanism? It is going to increase the acetylcholine. So that means the cholinergic activity is seen in this patient. So if I want to increase the cholinergic activity, what is the patients will be having the function? What is the patients will be having, guys? So the patients will be having the bradycardia that will be seen in the heart function, and there will be decreased bronchus. So bronchospasm, bronchofunction will be decreased, bronchospasm will be seen. In the eyes, it will be presented as a meiosis and lacrimation. Okay, more and more fluids will be coming here. And if the patient having the GI, so the GI motility will be multiple times, it is increased. GI motility will be increased in this patient. Sweating. So for the sweating, we have the nicotine receptors, and also salivation will be seen. Coming to the energy, it will be doing the glucogenesis, and other one is the erection. All this will be seen with the parasympathetic nervous system. Okay, so parasympathetic nervous system, these are the points that you have to remember their main function. Next, coming to the sympathetic nervous system. So this is flight and fight hormones. Where it is present? It is present from the T2 to T12. Okay, thoracic vertebrae. And it is going to be the catecholamines. The action will be the catecholamines. Right? Catecholamines means epinephrine and also norepinephrine. Coming to the heart, let's start with the heart. It can cause the tachycardia. It can increase the ionotropy, right? Contractility will be increased from the heart, and it can cause the bronchodilation will be seen. Opposite is that for the vaso, it will be causing the vasoconstriction, which will be seen with this. And also along with that, we will be having the decreased salivation will be seen with this patient. Okay, the decreased salivation will be seen. Other than that, you will be having the urinary retention. Coming to the energy and also GI motility will be also decreased. Energy, it is going to consume the energy. So glycogenolysis will be seen in this patient. And coming to the reproductive, it is going to cause the ejaculation. Ejaculation will be seen with the this one. Next, what are the examples between the parasympathetic nervous system and the sympathetic nervous system? The most common examples that you have to remember for the exam, that is the OP poisoning. Okay, OP poisoning, it is going to cause what? It is going to cause the irreversible, right? Irreversible and competitive ACH blocker, acetylcholine blocker, right? So there will be increased parasympathetic system, increased cholinergic symptoms. Just now I said what are these? All secretions will be seen in this patient. So the triad that you have to remember for this. So first one is the pinpoint pupils, and other one is the secretions and distress increased respiratory distress. Other like opioid or other poisoning, secretions will be not seen. Secretions is only seen in the opioid patients. And what is the drug of the choice for this patient? So the drug of the choice for this patient is the atropine to decrease the cholinergic. But it is causing the irreversible damage. That for that we have to add this patient as a parilodoxine. Okay, oxime drugs can be added. What does this oxime drugs will be do? This is going to reversible the action of the ACH. That is the main drug action of the parilodoxine. Next, what is the example here? The example that is here is the atropine poisoning. Atropine poisoning. It is going to be increase the sympathetic nervous system. So the patient will be having all the dry symptoms, dry mouth. Okay, the patient will be having the severe abdominal pain because it is going to be GI motility is decreased. It can cause the ischemia also, right? The dry mouth, abdominal pain, and also dilatation of the pupils. All this will be seen in the atropine patient. So the drug of the choice for this patient is the physiostigmine. Okay, physiostigmine that should be given for this patient, right? Next, moving on to the all the ANS drugs that you have to remember. Some of them are the direct agonist drugs of the parasympathetic nervous system. Those are the pilocarpine, which will be increasing the parasympathetic nervous system. This is used in the acute closure angle glaucoma. Acute closure angle glaucoma, I can give the pilocarpine. Next, bethanocol. So bethanocol is used for the post-op bladder. So those who are having the post-operative bladder, like retention of the urine, there I can use for this bethanocol. And also methanocol. Methanocol, actually what I said, it is causing the bronchospasm. So methanocol is used for the asthma patients testing. So if I give the methanocol, they're having the bronchospasm, so they are likely to having the condition of the this asthma. So this is for the testing. Next drugs, those are the indirect drugs. So what are these indirect agonists? They are going to block the ACH enzyme. So that means increase the ACH levels. This enzyme, once it is blocked, it is going to cause the ACH levels in the body. So examples is donepezil is used for the Alzheimer patient, right? Next, physostigmine, just now we discussed, this is used for the atropine poisoning and also acting on the datura poisoning. This can be given. Coming to the neostigmine, in the neostigmine, it is used for the post anesthesia patients. Okay, next also it is pyridostigmine. Pyridostigmine, it is used for the myasthenia gravis patient. Next, coming to the antagonist. So if I say antagonist, parasympathetic nervous system is blocked, but still it is going to increase the sympathetic nervous system, right? So sympathomimetic drugs these are. So if I use on the bronchi, so that will be triotropium and also ipratropium. If I use this on the eyes, those are atropine or the tropicamide. Okay, atropine half-life is around 1 week. If I use by the eyes, myotics, and for the CNS, it is the benzoxazole for the Parkinson's patient, and for the urinary bladder, it is going to be the solifenacin. Solifenacin. These are the drugs, right? Next, what is the drugs that will be associated with the alpha beta? So, alpha 1 agonist. Agonist again, sympathetic nervous system will be increasing here. These drugs are the sympathetic nervous system increasing drugs. So, these drugs will be phenylephrine used for the patients, those who are suffering from the hypertension, right? Next, phenoxybenazine. Where is this phenoxybenazine used, guys? See, this is used for the pheochromocytoma. Pheochromocytoma patients, I can use this, right? Next, alpha blockers. Alpha blockers. That means sympathetic nervous system is decreasing here. These are prazosin used for the benign prostatic hyperplasia, scorpion bite, and also hypertension. Second generation is the tamsulosin. This is used for the BPH and also post DJ stunt patient also we can give this drug. This is the beta blockers, right? Next, the other drugs is commonly the beta blockers, the classification of the beta blockers, and all these drugs can be important for the examination. Next, moving on to the some of the miscellaneous topics such as gout therapy that we are going to discuss. Then we will be discussing of the cardiovascular drugs also. In the gout therapy, you have the drugs such as acute gout. What is the drug that we are going to give? So the first choice is the NSAIDs. If it is not decreased with the NSAIDs, then I'm going to go for the colchicine drug. I'm going to go for the colchicine drug. What it will do? It will decrease the neutrophil or inflammatory migration, which will be decreased with the colchicine. It is an add-on drug, not the drug of the choice. Next, if it is a chronic patient, I'm going to give the allopurinol for this patient. I can give the allopurinol. What is the mechanism of the allopurinol? This is the xanthine oxidase inhibitor. This is the xanthine oxidase inhibitor drug. Those who are suffering from the pseudo gout. So for this pseudo gout patient, I can give again still NSAIDs because this is not associated with the uric acid. For the patients who are suffering from the tumor lysis syndrome, for this patient I can give the raceburicase, and the main drug of the choice for this patient is the probenecid, febuxostat or the probenecid, right? These are the drugs that I can give for the patients of the gout therapy. Next, coming to the hypertension. Hypertension is two types. If the patient is presenting from the acute less than 60 years, or the patient is coming from the more than 60 years. If the patient is less than 60 years, then I will be going for the ACE or the ERB drugs. If the patient is coming from the more than 60 years, then I'm going to give this patients with the calcium channel blockers. This is how I'm going to give. And if the patient is presenting from the hypertension urgency, then I'm going to give for this patient oral drug, oral clonidine that I'm going to give. If the patient is suffering from the emergency, that means the patient is actually having the end organ disease, right? So morbidity will be seen, multi-organ dysfunction. So for this patient, I'm going to give the IV. In the IV, I'm going to give the nicardipine for this patient. Labetalol is commonly given in our settings, but the drug of the choice, if they ask, that is the nicardipine. Next, hypertension with the resistance. In this hypertension with the resistance, the drug of the choice is the spironolactone. Spironolactone drug is given for this patient. Next, another phenomenon commonly asked for these patients is the hypertension with osteoporosis. So these patients I'm going to give the thiazides. Okay, and hypertension with the diabetes mellitus, or the patient is with a CKD, or the patient is having the heart disease. So for this patient, we can give the ACE inhibitors. Okay, ACE inhibitors or ERBs drugs can be given for this patient. Next, hypertension with the Raynaud's or any other patients. For this patient, I'm going to give the CCB, calcium channel blockers, that can be given for this patient. Next, classification of the beta blockers. We have the beta blockers. This is going to act on the beta blockers, right? It is two types. One is the non-cardio selective and other one is the cardio selective. Okay, other one is the cardio selective drugs. So what is the difference between the cardio selective and the cardio not selective? Non-selective drugs are commonly used for the other conditions, okay, like just like in the migraine patients that we used. Example is the propranolol. This can be used for the thyroid, this can be used for the migraine and other conditions, anxiety conditions also. Cardioselective is selectively used for the hypertension patients or patients those who are suffering from the MI. This conditions is given for the cardioselective drugs. They are special drugs such as carvedilol. So carvedilol is not just acting on the beta, it will be also acting on the beta blocker and also alpha blocker. Next, one of the drugs that is the nebivolol. This nebivolol is used for the nitric oxide also. Nitric oxide release. It will be seeing the nitric oxide release. And carvedilol, it is also having the calcium channel blocker also. It is acting as a calcium channel blocker also. Next, labetalol. Labetalol is used for the pregnancy patient, most pregnancy safe. Same action, it is going to be having the both alpha and also beta blocker. These are the some of the important points. The most cardioselective, the most cardioselective, that is the nebivolol. And coming to the other important, the longest is the nadolol, very shortest, or the landiolol. Very shortest is the landiolol. This is the cardiovascular drugs that you have to remember. And some of the important points, for example, if they gave the scenario, for example, the patient is presented with the AFib, what is the drug that you are going to give for this patient? If it is a chronic, if it is a chronic type, then you can choose the beta blockers. Okay, if the rate and everything will be normal, then you can choose the beta blockers. But if you cannot control, the rhythm is completely disturbed, if the rhythm is completely disturbed, then we can go for the amiodarone. Okay, amiodarone can be given for these patients. Next, those who are suffering from the WPV syndrome. So those who are suffering from the WPV syndrome, the commonly the drug of the choice for this WPV syndrome is the flecainide. Okay, we can give this patient is the flecainide. But if I have to choose for the IV, if the admission, then I will be choosing the prokinamide. This is a drug of the choice. But the treatment of the choice will be ablation. Ablation should be done for this patient, right? Next, moving on to the some of the important points that you have to take note. The miscellaneous drugs. One is the ivabradine. This is going to block the funny channels, funny sodium channels. That is the ivabradine. Next, recently in the INICT they asked about the clinidipine. What is the blocker? This is the N-type N-type calcium channel blocker. Okay, funny sodium channel blockers. Next, very old question, that is the nicarundil. This drug is going to be the calcium channel opener. This is the calcium channel opener, right? This question has been also asked in the different exams. Okay, these questions and their mechanism, that is very important. Next, coming to the amiodarone side effects. Amiodarone side effects. What is the side effects of the amiodarone? Mostly it is going to cause the photosensitivity and pulmonary fibrosis also seen. The patients which will be suffering from the corneal corneal micro deposits, which will be also seen in these patients, and myocarditis, liver toxicity, thyroid toxicity, that will be seen with the amiodarone. Next, digoxin. Digoxin having the side effects such as It is an arithmogenic. So if this is actually going to block the sodium potassium ATPase blocker. Okay, this is the sodium potassium ATPase blocker. So these patients will be increased of the potassium inside the body, and also it will be triggering, right? So increased risk, this will be associated with the bigemini arrhythmia, which will be increased risk. If it is not controlled, the patient will be having the more and more risk of the arrhythmias also seen. Next, other side effects such as gynecomastia. Gynecomastia will be seen in this patient, and also ocular symptoms like halos, yellow vision. These are the similar things that you are going to see in this patients. So the things that you have to remember here is the mechanism of actions and everything, the drug of the choice. And also I have done the other two videos, pharmacology part 1 and part 2, where you are going to have the more elaborative of the CNS and also the epileptics and ANS drugs, where you can listen guys. And here the some of the pharmacology, the basic pharmacology I will be explaining here. Okay, such as enzyme inducers, enzyme inhibitors. What are those drugs that we are going to discuss here? So enzyme inducers. What are the enzyme inducers? And what are the enzyme inhibitors? What is this main mechanism of the enzyme inducers? Basically, these drugs is going to cause the drug failure. These drugs can cause the drug toxicity. Drug toxicity will be seen enzyme inducers versus the enzyme inhibitors. So the drugs that you can remember is the Griseoflavin, rifampicin, all bad habits like alcohol, cigarette, alcohol, these two bad habits, and phenytoin, phenobarbital, phenobarbital. These are the drugs, and carbamazepine. And the drugs that here present is the valproate, isoniazid, quinidine, erythromycin or the clarithromycin, right? Erythromycin and the clarithromycin, and ketoconazole. Ketoconazole. These are the drugs that will be enzyme inducers and the enzyme inhibitors. All right. Next, these are the examples that you have to remember. This can be also asked as a very short question, guys. And other, I have also explained again the receptors and important points. And please watch the other two videos also. Okay, that is also very important, guys, where I have explained all the important of the CNS, ANS drugs and CVS classification also. Okay, that is very important, and different side effects and associated conditions. What is the drug of the choice, antibiotics mechanism, and also the anti-chemotherapy drugs. Sorry, so I have not discussed here. So we have that anti-chemotherapy. So anti-chemotherapy drugs, what are the anti-chemotherapy drugs? So this is associated with the side effects most importantly. Rather than thinking of the more of the what are the types, you can remember with the side effects. So ototoxic first. Okay, ototoxic, and also nephrotoxic. What are these drugs? This is cisplatin, and carboplatin, ototoxic. Next, heart toxicity is highly associated with the heart toxicity, doxorubicin, donorubicin, and transituzumab. Next, myelosuppression. That means complete blockage of the bone marrow. That is associated with the fluorouracil and also methotrexate. Next, urinary bladder, hemorrhagic cystitis, cyclophosphamide. cyclophosphamide. Next, pulmonary fibrosis. Pulmonary fibrosis. This you can remember like a vehicles, bus fulvin, methotrexate. Sorry with the spellings, guys. Methotrexate, nitrofurantine, nitrofurantine, bleomycin, bleomycin. These are the drugs that will be associated with the pulmonary fibrosis. Okay, so just remember, watch that video also and watch this video. Please practice this again and again, and so that you will be remembering for the long time. Okay, so remaining the drug of choice, some will be discussed in the micro, some will be discussed in the patho, some will be discussed in the medicine, and ENT, Ophtha, those drugs also again discussed separately. So please focus on the pharmacology and increase the maximum score in the final examination. So those who are interested to have these books, you can text me in the Telegram. And until then, please do subscribe and share with your friends and like the video so that it will reach the more students. And thank you guys. Happy preparation.